Hey everybody, this is Dr. Perkins, bringing another video. I just wanted to kind of go over some mechanical ventilation modes. There'll be some OR stuff put in here. Some of it'll be uh, ICU driven as well. So kind of a little background of what I do is in 1999, I went to undergrad at University of Missouri and I want to go to medical school. And so they tell you, you can be biochem major, biology major. I don't know, there's a few different ones. And none of them have anything to do with actually touching a patient, learning anything about medicine whatsoever. So I did biochem for like a semester, and all you learn is plant genetics. So I kind of moved on from that, and I saw a School of Health Professions. It was right across from my fraternity. So I looked through the course catalog there, or the majors that they had, and so they had a whole slew of different things, and one of them was respiratory therapy. So it was at the time in 99 to 03 when I was there, it was the only undergrad respiratory therapy major in the country. So I think there's quite a few more now, but there's all kinds of stuff you can do before going to med school. And I would always suggest to people, anyone who ever asks my opinion, I always say you should do something, nursing, radiology tech, ultrasound, PT, OT, respiratory, nuclear medicine. So I always think it's good to get into medicine before you try to get into medical school. So it's kind of the background. So when I went to medical school in Kirksville, Missouri, I was there for 2 years. And then during my third year, I was doing some rotations, and I did a 2-week rotation in anesthesia. I really didn't know what I wanted to do. I was supposed to go back to my small hometown in Northwest Missouri and be a family practice or internal med doc, and went through anesthesia for 2 weeks. And they told me, since I was a student, I have to do a lecture on something. And they asked me if I knew anything in anesthesia, because you'd never learn anything in anesthesia during the first 2 years. There might have been like one day, maybe, I don't remember. I was like, well, I know vents pretty well. And I think they kind of laughed at me. I didn't really tell them what I did until I did the lecture. So they're like, oh, okay, well, we'll suffer through this lecture the next day. So I went home and just kind of made however many slides this is. I've augmented a few times, and gave them the lecture the next morning. By about slide 3, no one had any clue what I was talking about. Attendings, residents, fellows, med students especially, and gave me a real good advantage of applying to an anesthesia residency. It's kind of interesting. Even, you go through, we do CRNA training here at Western Missouri Medical Center, where I'm the chief anesthesia, and med students, residents, everywhere I've gone at the 12 hospitals I've been to, nobody ever knows that much about mechanical ventilation. Even in the anesthesia world, I'm always surprised at how much isn't in the books. We got all these books about everything in anesthesia, and we mechanically ventilate people every day, and it's always amazing the amount of knowledge that no one ever gets taught to you. And it's not in the book, and no one really knows it that well. You can technically get by, but the how and how stuff works is kind of interesting. So that's kind of the background. So obviously I got into anesthesia, and my knowledge of mechanical ventilation helped me a ton. So, and especially when you're on rounds and they're asking people questions in the ICU or anesthesia or something like that, usually after you know something like this, they don't think you're going to know. They just stop asking you questions. So that was kind of nice. Okay, so we'll kind of just go through. Like I said, I'm going to sprinkle in some ICU stuff with it, some OR stuff, as far as when this stuff's important, and what the different modes are. So we'll go through here. So types of ventilation, we got non-invasive and invasive. This is pretty simple. Most people know this. So CPAP. So really, if you have somebody with low NO2 that's struggling to breathe, really CPAP's all that you really need. PEEP, CPAP, EPAP, all of those things. Once we learn these, they're pretty much the same thing, depending on different invasive, non-invasive, or a inspiratory and expiratory delta pressure change. It's all the same thing, and they all control your oxygen by stenting your airways open and preventing atelectasis. Okay, So obviously obstructive sleep apnea it's good for, but really someone on the floor could just do a lone CPAP instead of a BiPAP if their ABG looks okay, but they're struggling to breathe. CO2 readily crosses, the alveolar capillary membrane a lot easier than oxygen. So some people will have just a good ABG minus this, and they have some dyspnea and increased work of breathing, accessory muscle usage. Really, a lone CPAP would be good for them. Most people just get put on BiPAP, which sometimes can push their CO2 down. So another non-invasive, we all know what BiPAP is. So here's kind of the indication. These acid-base disorders, like I said, if you don't really have the acid-base disorder and you just have hypoxia or hypoxemia, then that's a great thing for that. So, of course, obstructive sleep apnea, if it gets bad enough, sometimes they obstruct so bad they need a higher level pressure on inspiration to keep the airways from collapsing, the upper airways from collapsing, as opposed to a lone CPAP setting. So once you get up to a lone CPAP of 15-ish, 13, 12, somewhere around there, a lot of times you'd rather switch it to BiPAP, and when they inspire, have a higher pressure to minimize minimize the mean pressure throughout the inspiratory and expiratory cycle, but also to minimize the amount of gastric filling with air with lower pressures. So here's some other indications. Of course, contraindications, you see this blown by all the time. So unresponsive, I mean, how many times do we go into a room and a person's on a BiPAP? Now, if they're a DNI, someone doesn't want to intubate and they realize this person's pretty close to death, I don't think that's contraindication if they want to throw some BiPAP on there, see if it, spruces them up a little bit. But, on everyday person that's not a DNR or DNI, unresponsive is really a contraindication to it. So if you're not awake, somewhat awake and alert, and be able to protect your airway, which is the next one, you're going to aspirate, so whether it's secretions, food, whatever. We just talked about secretions there. Of course, a no and a weak cough, that's not good for BiPAP. You'll eventually build up mucus plug, upper airway, mucus, and that's not going to work very well. Facial trauma, obviously, if you have to wear a mask, it's kind of hard to be on BiPAP in the hospital and have to have just a nasal mask on. That doesn't work very well. So the nasal is pretty much for OSA, and then the facials for everything else. Although some people with COPD that can go on and off of stuff like that, they kind of get used to, maybe I can do a BiPAP through the nose. So. And then they kind of have a general pH. This is kind of a relative, if you want to try it below that, you can. But a lot of times the acid-base disorder is so severe, they're probably going to be unresponsive to begin with because their CO2 is so high that it's contraindicated anyway. So. All right, so here's just kind of a non-invasive BiPAP indication that came from the AARC. And you can read that. Pretty self-explanatory. Generally, you can start settings whatever you want. I mean, this is just kind of a general setting. So when you set in a BiPAP, this is an IPAP, EPAP, inspiratory positive airway pressure, expiratory. You're going to try to get some return tidal volumes. They got to have a good face mask fit for you to be able to calculate that. And this is ideal body weight, not actual body weight. If you look at that, and I'll have a slide later that talks about ideal body weight when it comes to tidal volume assessment. And so when you look at these, most BiPAP machines, when you do this, the 12 centimeter IPAP is going to go on top of the 5 centimeter EPAP. So your peak pressure should be 17-ish. Okay, so it's not 5 plus minus that. So your delta usually isn't 7, depending on which machine. Your delta is 12. But if you see a peak of 12, then you know that delta 7 on that machine. So you do set a eye time on most BiPAPs because they don't really have like a pressure support setting, which they probably should. And maybe they do now. I'm not a respiratory therapist for the last 15 years. But to my knowledge, they don't have that. So usually you set an eye time, and this is just a backup rate. Like I said, you shouldn't be unconscious of this. So it does have a trigger. Usually it's a flow trigger, which we'll talk about later, the different triggers. But they should trigger pretty much every breath. And if they don't, there should be an alarm and the backup's kicking on. And that's when you got to do a further assessment if something else needs changed. Of course, we're going to titrate just to keep them not hypoxic. So make sure I don't go too many slides here. So here's indications. That's kind of non-invasive, real quick with that. Of course, anything that's severe, they're going to meet criteria, or they're going to have contraindication criteria to non-invasive ventilation. You can always try it. It's not going to hurt anything. It's just, you don't have to mess with their airway. So, if they have a known difficult airway or some type of syndrome that you think they'd have real difficult airway, maybe you could try this first, and you would kind of go against some of the relative contraindications to begin with. So, of course, there's your contraindications. The severe, we talked about, less than 7.2. Of course, these are usually progressive. And I can't say we see polio, but that was on there. But muscular disorders where you're talking about muscle strength weakening, you're also going to have a weak cough, not be able to clear your secretions. If you're in some type of crisis, or Guillain-Barré is getting worse, so the ascending, descending myopathies, then usually those are ones you're just going to have to tube for. So, and of course, when you get SIRS, a lot of those people end up getting intubated. So they get a pretty good acidosis with it anyways. And you do have to watch an active upper GI bleed. We tie this into anesthesia. If anyone has an active upper GI bleed that hasn't stopped and they haven't been taking in clear liquids, for a little bit and not thrown up, you're pretty much, when you do the anesthesia for them, you're kind of tied into doing a RSI, generally T-tube, or general anesthetic with an ET tube, just to protect their airway. So, okay, let's go back. So here's kind of the modes I wanted to go over. Oh, you know what? Another one I want to say is angioedema here. So not necessarily in this, but one that you're literally, what's going to happen and you want to protect it. So, angioedema, you don't want to put a BiPAP on, plus their face is going to be all swollen, at least their lips. So invasive ventilatory modes. So some of these have different names as we go through. I'll try to remember some of them. Different vents call them different things, but they're the exact same mode. Just, it's like someone having trade name versus generic name, but it's just different companies that can call it something else. So we'll kind of go over all of these. We'll talk about them individually, and we separate invasive modes from controlled or spontaneous and assisted. So most of these are assisted. This is the only one that's completely spontaneous. So graphics and waveforms, we'll look at this one next, but these are on our anesthesia vents. They're on most of the ICU vents too. So this one doesn't have too much need for it, but it does show that in this time, this is pressure. It does show that this is kind of old school. It tells you how they used to do it before there was microprocessors. Is this patient's triggering a breath. It's a pressure controlled breath. And it was a pressure trigger, which you really I don't even know if that exists anymore. But back in the day, before microprocessors came, you would have to create a negative pressure to trigger a breath by the vent. So you can imagine that's not very nice to some people, especially if you're auto-peeping, you have obstructive lung disease, you can't even exhale all the way. It's hard to trigger the next breath if it's a negative pressure. So now they're all flow triggers, which we'll go over here in a little bit. This one I use all the time, especially in anesthesia. So this is inspiration, this is expiration down here. This X line is time, and then this is flow on, what would that be? The Y-axis here. So this is peak inspiratory flow, peak expiratory flow, and this is expiration. This is expiratory time from here to here. And then this kind of shows you how close it gets back to baseline. So this is a really good indicator of obstructive lung disease. So we'll look at our, I don't know if I have capnography on here, but your CO2 waveform is usually a nice square in the OR, right? And a lot of the ICU vents have them now. And if you have really bad obstruction, you'll see a CO2 waveform that goes up and then kind of gradually has a trend going up after the initial vertical line. And just like this, the flow generally goes like this, doesn't get back to baseline. As you can see, this one does. So I think I got a slide on that. So this is a normal flow time pattern, or I guess graphic. And then, so loops are important. This one's more for like PFT stuff here on the right-hand side. But on the left-hand side, these are on most of the anesthesia vents too. They're usually on a different screen. You'd have to actually select to get. But as you can see here, this is inspiration, this is expiration, pressures on the x-axis, volumes on the y-axis. So in general, wherever you make a tangential line, and hopefully you can see my cursor on this, but as you go up, here's a negative inflection point. And this is where you get a gain. This circle labeled as B. This is where you get a gain in volume for gain in pressure. So therefore your compliance is best on that line right there. And if you kind of draw a point from A to C right here, just one flat point, kind of tells you what their compliance is. So if it's going like this and numbers don't change on these, and then you look back, during second part of the case, and now A's here and C's down here, that's where you'll see a change in compliance. So if a flat line's drawn out here, compliance is lower down here. If the line from A to C goes up, general compliance is better there. Okay. So I'm going to think right here. Yeah, this kind of gives you an idea of a A to C line, which low compliance, normal, and then high compliance. This is a good one for ICU. And a lot of times this is best if you have, and this graph kind of sucks, but it kind of showed exactly what it is. So here's the lower inflection point we were talking about here. Here's the upper inflection point where pressure past this amount, you don't get much bang for your buck when you're talking about return or tidal volume. So you don't get much volume in with an increased pressure right here. So your compliance is best right here. This is overcoming the resistance of the airways. Usually here the airways are open. Here's where you get good compliance. And then up here, your compliance is kind of going south. It's not negative, but you're getting very little volume for the amount of pressure that you have to change. Okay. And so this is over distension in ICU. This is a pretty good graphic of say someone's paralyzed too, especially if they're paralyzed, and this is happening, then your tidal volume's too much, or your set pressure. If you're on a pressure mode, your set pressure is too high, and if you're on a volume controlled mode, then your volume is too high. So assist control, AC, if you ever hear that. There's VCAC, PCAC. These are fully supported ventilations. You can see in volume that flow is consistent. So if you ever have a test question where it says, hey, you're in volume control, what is consistent during inspiration? It is flow. Pressure can vary, and that's due upon compliance. Okay, so a set volume is given over a set amount of time on an inspiratory time that's dialed in. And we'll do some calculations later, real simple ones. That'll kind of show you how to calculate your IE ratio, I time, expiratory time, stuff like that. And if it's a volume control mode, you could even it used to be you could set your flow to that, but now it's just automatic with how much volume you're putting over how much time. So flow is constant. Pressure is constant. Pressure control, that makes sense. So this is PCAC. This is VCAC. So PCVC, or sorry, PCAC, pressure control, assist control. The inspiratory time is still a preset amount, so it's calculated in there, and a set centimeters water pressure over that I time is given. Whatever the compliance is will determine what the tidal volume return is. If compliance changes, then if that pressure control does not change, if the compliance goes down, then your return tidal volume will go down. And if your compliance goes up, which is how many mils of tidal volume you get for a change in 1 centimeter water pressure. So both of these, you can, I think back in the day, you could do it to where these were, you couldn't even get an assisted breath, but every microprocessor driven vent, which is every one I've ever seen from year 2000 to now, they're all set to where you can trigger, which is usually a flow trigger, extra breaths above the set tidal volume. So if you think someone, if you're just sedating someone, they're not paralyzed, I don't know, as an ICU doc, I would never increase the respiratory rate much above 10, because I know if they wanted more, they'll trigger more. Now, a lot of the sedation we'll give sometimes can lower the body's trigger CO2 and P little a CO2 and P little a O2 triggers for a breath from their diaphragm. But most of them aren't affected that bad. So unless the blood gas is way off, and I think they're way less than they should be, or excuse me, their CO2 is way higher than it should be, and they have a uncompensated respiratory acidosis, I wouldn't really go above 10, because most of them can do more than that. The only caveat would be if you're paralyzing them for whatever reason. And then I would use respiratory rate as long as peak pressures are below 30-ish. I'd use respiratory rate to guide my CO2 acid-base balance. So here's some volume control initial settings. So tidal volume, usually about 10 kilogram or mils per kilogram in ideal body weight. I told you there was a ideal body weight graph here. So 50 plus 2.2 inches above 5 foot. So, and females is a little less. So if somebody's 5 foot and they're a male, then you should have them about 500 mils of an ideal tidal volume for them on a volume control setting, which would also be similar to your target on a pressure control setting. So here's a 6 foot male, about 750 normal. And, anywhere 650 to 800 is probably normal. And their pressure is not going to be horribly high. Now, some of the things affect that we'll talk about later, but in the OR, obviously, we give people pneumoperitoneum and put them in Trendelenburg. Both those things are really bad on compliance. So sometimes you'll do a little lower blood pressure or lower tidal volume. So like I said, you just adjust these for blood gas as well. This is just general settings. You don't want, you're trying to avoid atelectasis and hypoxia without giving them barotrauma. So usually this atelectasis is avoided by having appropriate PEEP levels, and same with hypoxia as well as FiO2, but mainly it's your PEEP, and then your tidal volume, which controls barotrauma, and the MODA setting, which we'll talk about here in a little bit, if you have obstructive lung disease anyway. So generally, in the OR, we try to keep peak pressures below 30. I'll go up to 35 if they're laparoscopic Trendelenburg, because I know that's more pressure pushing on the diaphragm that's probably going to be transmitted to the peritoneum. So the actual pressure, that it's seeing might be a little less than that. But generally, we try and keep it below 30 in the ICU or the OR. And that's generally consensus to minimize barotrauma. Barotrauma is going to happen. And sometimes, you have to go up above this in certain situations, especially in the ICU, not too much in the OR, but ICU with pathologic processes. So you can up down your tidal volume. Usually you go about 2 mils per kilogram. Of course, in the OR, we just go by 50s mainly. So, and in the ICU, we recheck ABGs, peak pressures, all that. So, one exception to all this is back when they did the surviving sepsis guidelines and the ARDS, the acute lung injury and ARDS trials, low pressure was preferred lung protective strategy, especially if you know you might end up on this. The last thing you want to do is blast them with it to begin with. Most of that's driven by your P little AO2 and your SAT. A lot of times, these would get paralyzed, and if their CO2 goes a little high, you're not going to get too excited. And when we did that, that was called permissive hypercapnia. We would do that. That's mainly in ICU. It doesn't really have much to do with OR. So volume control, initial settings continue here. I think we kind of talked about this, the respiratory rate. So we want to shine on the low side. I think I kind of talked about that. It helps you with the physiologic blood gases. And the higher the respiratory rate, we'll see this in a little bit, the higher the IE ratio, which gives you less time in exhalation. And so people with obstructive lung disease that have auto PPing, we'll see here in a second, you can really stack breaths on volume control, and peak pressures can go up pretty quick. And, that's really bad for someone with severe obstructive disease. So this is really not a good, mode of ventilation for people with really bad obstructive lung disease. There's much better ones. So the higher breath rates here would be bad for severe obstructive lung disease, but as we talked about before, in the ALI ARD scenario with lower tidal volumes, higher respiratory rates, trying to keep their blood gases somewhat physiologic, that's a good strategy. So that would be about the only time I raise their respiratory rate a little bit. A lot of times I just paralyze those people, and the more you're in anesthesia versus ICU, people in anesthesia, we don't think twice to paralyze people. We think everyone should be paralyzed, really. If you got a breathing tube in, you should probably be paralyzed, but that's just our swaying of our thought process because of what we've been working with. Everyone does get pretty much paralyzed for the most part. But with the advancements in reversal and Sugamidex that's come on in the last 10, 12 years, it makes reversing paralytics pretty novel now. So it's not as bad as it used to be. So inspiratory flow rate, this used to be dialed in, and if you see like an old ventilator, sometimes you'll see like an old transport ventilator, maybe an MRI ventilator that's purely pneumatically driven. It's not a bunch of microprocessors running it. You might see an inspiratory flow rate that you have to type in. So mainly this is an ICU and respiratory therapist, about all you need. But the autoflow and flow demand with microprocessor driven vents now in ICU and the OR, you really don't have to mess with that. But just for reference, 60 is about normal on an inspiratory flow rate. So let's see what else I can say about that. And then sometimes you'll see these ramp or rise settings on here, and it is exactly like they are on a CPAP or a BiPAP, like a home CPAP or BiPAP. Actually, the hospital ones have this too, but it's basically how fast it's going to get to the peak. So there'll be a set peak on the microprocessor, say it's 60 liters. Are we going to get there in 0.1 seconds, 0.2 seconds? Or are we just going to ram 60 in right away? So a lot of that has to do with patient comfort and adjusting that. You guys probably don't have to do that. In the OR, it's not even an issue because that's not an option on any of the OR events. Everybody's sedated and paralyzed, so we just ram her right in. So the trigger, I kind of talked about this a little bit. The flow trigger is way more sensitive and easier on patients to pull. Like I said, the pressure trigger was kind of mean to people because you're literally pressing against or pulling against a almost closed tube. Even if you had PEEP on, it probably wouldn't be, but this would be probably before PEEP. So that was actually really bad because you're actually creating a negative pressure, which is the opposite of what you're trying to do, and creates more atelectasis. So all these microprocessor driven vents are now flow triggered. And the flow trigger is exactly what you look at it. So when you say, a normal flow triggers 2 liters a minute, literally you can go over to a nasal cannula output on the wall, where the oxygen comes out. And if you set your trigger at 2 liters a minute, that's how much they have to pull. That, just go put your finger by that. That's what they have to pull to get a assisted breath in the controlled setting. So same thing for it's a controlled breath, sorry, not assisted, but same thing with assisted settings like pressure support, whatnot like that. That is the same trigger on both of those, but what happens after the trigger is different. In a controlled ventilatory setting like volume control or pressure control, then that's what you'll get afterwards. Okay, so let's just pull this down. We'll go to the next ones. So the IE ratio here is calculated by the vent. A lot of times you can dial it in, especially in the OR. We usually have ones you can dial it in. Some of them are just calculated from your eye time, what you put in, the tidal volume, all that. So normal's 1 to 2 or less. So 1 to 2, 1 to 2.5, 1 to 3 is what that means. So with a higher respiratory rate, the IE ratio comes closer to 1 and increases the chance of auto peeping. So that's what kind of what I talked about later is normally you want 2 times the amount to exhale as you do to inhale. And we'll have a little thing down here we talk about, especially with obstructive lung disease. You don't want to be, if you're dialing in an IE ratio or a respiratory rate, you don't want either of those high. So people that are really heavily sedated, sometimes in real bad obstructive lung disease, you know, people that status asthmaticus, we've had to paralyze before in the ICU. It's kind of important to keep that IE ratio down and respiratory rate down to give them a chance to fully exhale. And I talked about this earlier. That's the kind of the permissive hypercapnia. Is your peak pressures are getting high, your auto peeping, your flow's not getting back to baseline. So there's a lot of times in the ICU where permissive hypercapnia is a thought process that's a protective lung strategy. So you're not blowing up the lungs and you're giving them a little longer to exhale. Even though the CO2 rises a little bit, as long as they have good kidneys, the acidosis should correct. So you'd have a corrected respiratory acidosis. Usually it fully corrects too over, you know, less than a day. So here's an example of the IE ratio. So we set the respiratory rate at 12 times a minute, and there's 60 seconds in a minute divided by 12. So the whole respiratory cycle is 5 seconds. They're not triggering any extra breaths. And so if you type in an inspiratory time of 1 second, the IE ratio is 1.4. So I did that just so the math is really easy, but you could make it to where you actually have to do a lot of calculations on that. So volume control settings continue. This will be kind of general because this goes for all settings, but your PEEP is your positive and expiratory pressure. So really, if anyone ever asks you what PEEP controls, it is oxygenation. That's one of the main characteristic of mechanical ventilation that helps prevent atelectasis. And as you're exhaling, keeps the airways from collapsing on themselves. And most of the time in ICU, if they have a pathologic process, they're collapsing easier than they should, whether it's fluid secretions, loss of surfactant, all this stuff. You know, there's some variety of things you could say, but this is what controls it. So that's why when we have really problems oxygenating people, not ventilating. So ventilating is CO2, oxygenating is PO2. And when you have problems with oxygenation, PEEP is the setting that you're going to try to augment. A lot of times we'll adjust our PEEP, trying to get the FiO2 down, because real high FiO2s, especially in neonates, is a bad thing. And even in adults in a prolonged setting isn't the best thing. But you're going to optimize your ventilatory mechanics with a higher PEEP. And one of the side effects is you might be able to come down on your FiO2, which is good. So, and PEEP is usually the most important factor of mean airway and interthoracic pressure, especially as it goes up. So remember, the expiratory phase is longer than the inspiratory phase most of the time. So mean airway, which is transmitted to interthoracic pressure, The higher you go on this, the higher it can come on your inner thoracic pressure. And this is kind of when you say, is PEEP really helping us? If your mean airway pressure gets up so high, somewhere in the 20-ish range, mid-teens, upper or low 20s, you might be compressing venous return from the superior and inferior vena cava and decreasing preload to the heart, which sometimes is not a very good thing. So, and I think I got a slide on that here in a second. So, and that's kind of what this runs through here. So intrinsic PEEP, this is PEEP that you create yourself. So if you ever look at someone who has horrible obstructive lung disease, you'll see the pursed lip breathing, as they call it. So they're exhaling, and they even have like a little PEEP valve people used to have. I don't know if that's a thing anymore, but as they're exhaling, you'll see them close their lips a little bit and push out through that. And what they're actually doing is creating their own PEEP valve with their lips that helps keep their airways from collapsing. We're talking the tiny airways, not the big ones, obviously. So intrinsic PEEP is also called auto PEEP when you're on a vent. We kind of talked about that. The expiratory waveform doesn't get back to baseline. And severe obstructive disease, moderate disease, you can see this. You can get an auto PEEP number. A lot of people in anesthesia, we don't really know that, but in the ICU, if you ever had fancy enough vents or the respiratory therapist ever talked to you about it, you can sedate someone pretty well or paralyze them because of anesthesia. I just want to paralyze them. You can do a expiratory hold to where the vent will not push in the next breath, and the microprocessors can actually calculate what their auto PEEP level is. So the nice thing is, if you have an intrinsic auto PEEP level, if you match that with an extrinsic PEEP level, which is what's given to the patient on exhalation by the vent, you can actually optimize your atelectasis, which is kind of cool. So I don't know if they do that anymore. That's been, 15, 20 years ago when I did that, but it's kind of cool. So this is kind of what I got all together, the best PEEP. So you up your PEEP so far, you can actually improve your compliance. So remember we talked about compliance was the change in tidal volume in mils over the delta change in centimeters of water pressure on the vent. Okay, and if you look down here, normal compliance on a vent, so I just put a normal person on a vent like we do in the OR all the time, about 50 mils per centimeter of water pressure on a vent's normal. And if someone's just breathing atmospheric air without an ET tube or anything like that, it's 200. So it goes to show you when the diaphragm pulls a negative 1 centimeter of water pressure, it actually is supposed to pull about 200 mils. So it goes to show you that, compliance when you're using positive pressure, it's a lot harder to expand the lungs when you're using positive pressure, as opposed to this is negative pressure created by an unintubated person from your diaphragm. So, but this is kind of what I was talking about earlier with the cardiac output. So, if you have a swan or anything like that, and you got an index, which we don't really use swans too much anymore, but it's kind of nice. You can use your central line too. It's kind of a rough estimate as your central venous pressure. But you can kind of use it to where, hey, our PEEP's going up. This looks, the ventilatory mechanics look better. The pressors that we're on, say they have sepsis or whatever, and they need pressors, the pressors aren't having to go up as our PEEP goes up. That's a good scenario. And then at some point, you up your PEEP so far, you're going to need more pressors because you're inhibiting that venous return to the heart. And so that's kind of what is meant by best PEEP. You're trying to optimize the ventilator. You're trying to optimize the cardiovascular system too. So since they're all intertwined there. So here's a good graphic auto PEEP I was telling you about. So here's inspiration, and this is a descending pattern. So this would be a volume controlled breath that has a ramp down on it. So it gives the breath high. A lot of times the ramp goes the other way because it's nicer to start here than to start here. So this is peak inspiratory pressure, or sorry, peak inspiratory flow. This is peak expiratory flow. This is expiration on this side, inspiration that side. And here's your expiratory phase of breathing, and this is where you see auto PEEP. So if this doesn't get back to baseline and the next breath is triggered, whether it be by the vent or the patient, this is where auto PEEPing happens. And you see this with severe obstructive lung disease. And this is a pretty significant one. A lot of times they'll come up like this. Hopefully you can see my cursor, and right about that tick right before the second breath, they'll get back to baseline. You still know they have some obstructive lung disease, but at least they're not auto PEEPing. So volume control is a horrible mode to put them on when they're auto PEEPing, because you can imagine, hey, they're not getting all the exhaled volume out, and then we're ramming another breath in there, whether they like it or not. So this would be a high respiratory rate auto PEEP. That's where your peak pressure is going to go through the roof, and whatever your setting is on your vents for peak airway pressure max, whether it's in the ICU or the OR, that's where we're going to see stacking of breaths, and larger tidal volumes keep being put in, and they're not coming all the way out. So your peak pressure is just going to start to soar, and it'll go all the way up to whatever you have dialed in on your peak airway pressure. So sometimes the default's like 50, which is not a good thing. Let's say you get a pneumothorax, you pop a bleb. Most of these people, if you have this significant obstructive lung disease, you're going to have some blebs somewhere. If you show a bleb, anywhere north of 40 centimeters of water pressure on inspiration, it's probably going to pop, and then you're going to have a real problem on your hands. So here's kind of the summary of the orders. Of course, sedation, that's a whole nother topic we could go into, which we're not going to. So here's your volume control. So you can see pressures here. This is time, this is time. These are all times on the x-axis. And the y-axis, this is flow, volume, and pressures up top here, okay? And you can kind of see that flow is constant. So this person almost looks paralyzed because it's a perfect thing. So flow is constant. So this is a volume controlled mode. So under volume control, your flow is constant. There's no ramp on it. It doesn't go up like that. And the ramp, I don't even know why you'd have a downward ramp. I don't know. I don't think it makes a difference too much. Most people are so sedated or paralyzed, it doesn't matter. And then you can see right here, hopefully you can see my cursor, but right on the Y zone up top, if you see Y, so X is inspiration, Y is still considered inspiration, but that's actually an inspiratory pause. And this will be significant when I talk about compliances later. And then Z is exhalation here. So you can see Z is exhalation. But this is actually an inspiratory pause on a vent. And if you ever want to look at static versus dynamic compliance, so static compliance is Y scenario. You got an inspiratory pause. There's no other breath going in, and you're seeing what your tidal volume change over the delta pressure is. And that's where you get your your static compliance. Your dynamic compliance gives you an idea of the difference between the upper airway pressure and what the actual lungs compliance are. So say there's a big secretion in the upper airway, there's a fixed tumor in the upper airway, you would see this peak pressure be significantly higher than the inspiratory pause where the static compliance is. So dynamic compliance is at the peak where X meets Y, and you would take that over tidal volume, which would always be lower because it's going to be a higher amount of pressure. And then static compliance, you would see right here, this is actually what the lung compliance really is. The actual lung tissue doesn't have anything to do with the upper airway resistance or fixed obstruction, mucus plug, stuff like that. So that's where you see this inspiratory pause at Y, and you can tell there's no flow. Looking at the second graph on Y, there's no flow, and the pressure is still elevated on the inspiratory side, and you can see no volume change there. Okay, so that's what it would look like. But this is just regular old volume control mode. So here you can kind of see this person definitely has obstructive lung disease. Similarly, I never use this in the OR. I can't remember. Somebody used to change it to this all the time. And I don't know, it just triggered me being the respiratory therapist I was. But I'm like, what does this tell you? I really don't know. So, because it's not like you can't see the return tidal volume on the right side of every vent there is anyway. So, but the flow is definitely important. Trigger here, you can see this is probably a pressure trigger. This is probably an older graph of before they had flow triggers. But you can see this person definitely has obstructive lung disease. And we talked about pressure control, so same thing, but pressure is constant over that I time. So sorry, I want to go up and down a bunch. Okay, so when we talk about weaning, we're going to go over modes that are not completely controlled / assisted. Because there's assisted triggered on control modes, but really all you're doing is initiating the breath and then the vent takes over. So here's kind of weaning off modes. This is more ICU stuff. So whatever they got intubated for that, whatever it is, got better. You know, their sepsis got better. They're off pressors, whatnot. You know, alert, following commands, sedation holidays. You know, take them off station, see where they're at. Especially with the Presidex now makes it a lot easier than it used to be. We used to just kind of turn all the sedation off at like 6, and then you know, you'd have to start talking to them about 7 or 7:30, and some of them would just go ballistic, which I didn't really blame them. So, but that's kind of the indications. Kind of got to, whatever happened, it's got to get better, and then they have to be able to protect their airway, which makes them be able to have some awakeness to them. So there's vent mechanics. So I never really heard of anything about this in anesthesia or med school or anesthesia residency, anything like that. So there's a NIP, or a negative inspiratory pressure. Generally, we would do an exhalation hold on that on mechanics when they were awake, and you tell them about it, and they'd have to try to suck on that tube as hard as they could, less than -20. So less than -20 or below was pretty good. -15 was kind of intermediate, but if you could get a negative pressure, 20 centimeters of water pressure, that was pretty good on a NIF. Negative inspiratory force was the other term for it. The vital capacity, if you could get above like 10, 15 mils per kilo of ideal body weight, that's good. Like I said, if we're on a pressure control setting before that, you kind of know the compliance for that. That would kind of give you an idea if they're on a weaning trial, respiratory rate, average tidal volume, which we'll talk about, I think, on the next slide with RSBI. Obviously, the sedation is a big deal. So pressure support. So in anesthesia, people use pressure support all the time, and I'll always ask some of the students or med students, CRNA students, even residents that were under me, and no one knew what the hell it really was. But we all used it all the time, so it's kind of interesting. So generally, a pressure support, you want about 5 or 15. 15 is pretty high. That'd have to be on a really small ET tube. So for kids, you know, that to make it equal, like down here where I talk about the pressure support of 5 centimeters, so that's 5 above your PEEP. So that's just a delta 5 is needed to overcome an ET tube of 8. So, and if you ever see a setting on a vent, which is not in the OR that I've ever seen, but in the ICU, they might call it something else. There, like I said, it's all trade name, generic name stuff, whatever. It's different vents, but tube compensation. So you would dial in the setting of the tube when you were on a weaning trial, and it would give an automatic pressure support that basically made it a level playing field, because an ET tube is always longer and more narrow than the patient's normal airway. So if you just put them on a room air trial, we used to call it a T-piece trial, not even room air. You could have a little higher oxygen, but you would just put humidified O2 at the end of a ET tube, and it would look like a T, and it'd be looking like a peace pipe on the other side where the humidified whatever FiO2 it was coming out. And you know, really, when we did that to those patients, if they pass that weaning trial, you got a really good chance that they're not going to need re-intubated, because they were actually at a less chance of being successful, because it's harder to pull through that ET tube than it is their normal airway. So when we remove it, it's actually easier than the T-piece trial. So that kind of shows you what pressure support changes. So here's where people don't realize. So inspiratory time is completely controlled by the patient on pressure support. I think that's the question that every person I ever asked gets wrong. But on pressure support, the I time is controlled by the patient. That's the whole point of it. They trigger every breath, and it's usually a flow trigger. Once they trigger that, inspiration is set up at that pressure that you set in. So if it's 7, and you're sitting at a PEEP of 5, so you have a PEEP of 5 and a pressure support of 7, they're going to get 7 extra. They're going to get 7 as they breathe in, which is on top of the 5 anyways. And sometimes the pressure supports aren't like that. You'll dial in 7, or say, you dial in 10 and 5 is the PEEP, then your delta might be 5. But some of the vents might have a delta of 10 and your peak would be 15. So you kind of always have to see which one you're using. Most of them, they add them together. But the inspiration is ended, so it's triggered by the person, then it's ended at 25 to 30% of peak inspiratory flow. So before microprocessor-driven vents, pressure support was not an option. So this is the important thing. The inspiration is ended at a certain percentage of peak inspiratory flow. So the microprocessor gives the 7 centimeters of water pressure, and then as you pull in, whatever your diaphragm is pulling itself in your body, your accessory muscles, all that, the more you pull, the higher the peak pressure, the peak flow. And so as the peak flow went up, it would actually calculate that instantaneously, and then it would cut the pressure off as you back off of your want to breathe in that breath, and it cuts it off at 25-30%, which is usually when the normal person is done with a breath anyways. So that's where the synchrony came from, the vent synchrony. Pressure support was just a huge thing when it came out, and that was before my time. Pressure support's been here since '99 that I know of, or 2001, whenever I started respiratory part of it. So no respiratory rate is dialed in. Some of them you can have respiratory rate. Really, that's just a backup. And that would be if you went apneic for X amount of time, which I'll show you. There's some other settings, but pure pressure support, you shouldn't have to dial in a respiratory rate. It's literally pressure, and then you have a trigger and an FiO2, obviously, and a PEEP. So, and then you have your PEEP alone trial. So this is kind of making everything fair game on that. At least they're not like on a TP's trial. So that's what you see when you see a CPAP trial. Probably, unless their PEEP is high enough that it equals the tube compensation part of what size their airway is, they're probably at a disadvantage even with a PEEP trial of 5. But it beats a TP's trial, which I don't know, you guys probably no one even knows what I'm talking about when I say that. But okay, PSV Pro. And this is what I was talking about, different settings and different vents have different stuff. So this is just pressure support. You put it on pretty much every anesthesia vents like that. You'll see all these other settings. Really, they have nothing to do with pressure support. They're just, if the patient went apneic for, say, 20 seconds, it might kick them back into this. So that's all PSV Pro is. And then you can read the rest down here, but sometimes some of these will have a setting that puts them back into straight pressure support if they trigger a few breaths. Even though they went apneic for 20 seconds, they might have got kicked back into a SIMV pressure control / pressure support mode, and then kicked back into the whole 100% pressure support mode. And we'll talk about SIMV here in a little bit too. So that's the exit backup mode. Okay, here's where we talked about. So weaning trials, obviously not much in the OR for this. This is more for ICU, minus this rapid shallow breathing index. I kind of like to do this in the OR to some of the students because no one usually has a clue what I'm talking about. But the RSBI came out 20 years ago or so. It was kind of a hot thing back in the early 2000s, but it kind of gave you an objective thing to say, hey, what's the respiratory rate? What's their tidal volume? And remember, the tidal volume is in liters. So, if you are breathing 20 times a minute and you're averaging, and these are all averages. So, during this trial, you kind of look on the respiratory therapist would look on there and say, hey, here's average respiratory rate, average tidal volume. So say you're breathing 20 times a minute at 500 mils per breath. So then your RSBI would be 40. Okay, and you want to stay below 80 if you can. Below 100 is probably okay to extubate in the ICU, but sometimes I'll look at it in the OR just to kind of get an idea or talk to students about it. But we control this a lot with opioids, respiratory rate there, so that does make a big difference. So here's some other things to look at for distress throughout the trial, usually 30 minutes in ICU, 2 hours, somewhere around there. And then remember, you always want the ABG before you switch them back, and that's if you switch them back. Sometimes you can just leave them on it, and they're going good for 30 minutes, 45 minutes, get the ABG, just leave them on it, and then you get the results back, and you're like, oh, this looks good, patient looks good, time to extubate. So here's what pressure support looks like. So you can see this is a pressure support with a PEEP. So here's a PEEP, say 5 centimeters of water pressure. You could technically probably call it an EPAP and an IPAP because there are two different modes of that. Now, the only difference between BiPAP and pressure support with PEEP would be that the I time is controlled by the patient here. So, and they probably changed that on home BiPAPs by now. That'd be my guess. I don't know that. But certainly for vent synchrony, you could either, unless they they teach the patients how to change the I time to their comfort, but you'd think they would just make it like this. So here's the important one in the middle of the screen is the flow versus time chart. You can see this patient has a little obstructive lung disease too. They get back to baseline. Of course, it takes a while. But if you see the flow, you can see it's variable. And that's how you know this is a pressure-driven mode, okay? And since pressure support and pressure control both will have the same pressure throughout I time, minus if there is a ramp or whatnot. So you can't really tell in that scenario if this is pressure control or pressure support. But I know this is pressure support, but if you go look at this, you see this is inspiratory time from here to here. Hopefully you can see my cursor. And you can see the flow goes up. Say that's what, 50 liters per minute, somewhere around there, 60. So what we say 60 was normal. And so the vent would cut off the pressure up here at 30% of that peak, and that's for every breath. So every breath, it's measuring peak inspiratory flow rate, and it's canceling the pressure and ending the I time at around 30% of that. And some of the vents do actually have a setting on there where you can change, say, I don't remember the range, maybe 20 to 40% of peak inspiratory flow rate is when you would change the pressure support setting of when I time is discontinued. And that's all for vent synchrony, or patient synchrony on the vent. So here's some criteria when you're talking about extubating. Generally you don't want to extubate someone that's on higher than 40 FiO2, because usually if you're on a vent at 40 of FiO2, it's going to be a lot harder to match that without mechanical ventilation. You're going to end up back on the vent for oxygenation reasons. Same with PEEPs of greater than 8. So generally you want PEEP back to normal, which physiologic PEEP is 8 for most people. So obviously hemodynamically stable. I talked about you don't want someone on pressors and trying to extubate them. That's not a very good idea. And the sedation, and obviously whatever they got intubated for, you want to make sure that's off. But here's some general criteria. This is for ICU, not the OR. And here's your pressure support on here, whether to extubate or increase your pressure support. And we talked about the ET tube. So I think a 7.0 ET tube needs a pressure support of 10 if you don't cut off any length to overcome the resistance of the size and length of the tube. So here we've kind of covered the most common ones. We'll go into some uncommon ones. You see heliox, oscillators, jet ventilators. I mean, this is getting deep. Now, when I did this and I gave this lecture in med school, I think that pretty much sealed the deal. I could pretty much go to about any anesthesia place I wanted to, because they had no clue what I was talking about. So it did help a ton. So here's some other uncommon ones we will go into. So I take that back. Not uncommon. This is the follow-up of the most important slide of what we're going to talk about this entire lecture, which is probably the best vent mode I put everyone on in the operating room. And really in the ICU, I don't know why you wouldn't use this anyways. I haven't used pure volume control in I mean, as soon as I became a physician in 2009, and I could actually, unless I had an attending make me do something, I would never use volume control because all the vents past them would have a volume guarantee type thing. So that's what this is: pressure control ventilation, volume guarantee, pressure regulated volume control. Really, it's not a volume control, it's a pressure control, but it made people feel warm and fuzzy inside to hear volume control was on the setting. But really it's completely pressure control driven with the target tidal volume. So this is the best of both worlds. You can keep an ideal tidal volume that you want to guide your pressure control to get and minimize the peak inspiratory pressure at that tidal volume. So you can see that this is excellent for the operating room, especially with changing compliance. And whether you're in the ICU or OR, changing compliance is a thing, especially in the OR. Of course, the ICU you're going to change slower most of the time. In the OR, we might change compliance drastically within 5 breaths. Say we intubate somebody, their compliance is X, and we're waiting for the surgeon to start. They put in laparoscopic equipment, they create a pneumoperitoneum with CO2, and so that pushes up on the diaphragm, it decreases compliance. And then, especially for gynecological stuff, prostate stuff, anything where you're tipping in Trendelenburg, you're going to change the compliance even worse. So if they're a really big patient, their BMI is really high, their compliance, their chest wall compliance sucks to begin with because of their size. Once you tip them down in Trendelenburg and you create a pneumoperitoneum, their compliance is going to be even worse. And this is the best mode to get the most tidal volume back at the lowest pressure. And as that changes, it's going to change the pressure. So like pressure control, it has a set amount of assured tidal volume to be delivered. So that should say volume control. So like volume control, there's a set tidal volume. Now that volume isn't what goes in, but it's what it calculates the tidal volume in return to target to. So this kind of explains it here. So initially pressure control and pressure control volume guarantee, or PRVC, PC plus, I don't know, there's all kinds of names for it. It's all gonna act the same as pressure control initially. So most of them will look at 3 breath scenarios, at least from what I read in manuals. So they'll look at 3 breaths and they'll say, okay, the compliance is 42 mils per centimeter water pressure. And then it'll calculate the tidal volume. The average tidal volume back in those 3 was 420. And you have dialed in 550 of what you want it to do. So it's going to want to increase the pressure after those 3 breaths and getting the average tidal volume with the average compliance. And it can change the inspiratory pressure going over the set amount of time for that the next 3 breaths, and then it'll redo it and see if it needs to increase the inspiratory pressure or decrease the inspiratory pressure for that matter, if compliance is changing again, or it's not getting to the tidal volume, or it's over the tidal volume. So pneumoperitoneum comes down, we take the patient back to supine on a prostate case. All of a sudden the compliance goes way up, and now the vent's like, oh, I just, you dialed in 550, that's what I'm targeting, and I'm getting back 800. And say the pressure, the inspiratory pressure was 27, it's going to take it down to 24 for 3 breaths, and it's going to look at it again, and then it might take it down to 21 for 3 breaths. So it's like having a respiratory therapist just sitting there, or even an anesthesia person, just personnel sitting there and changing compliance the entire time. So I have no clue why you wouldn't use this. In fact, a lot of the OR vents that have come out in the last 10 years actually make this the base setting, and they call it like VC plus, and that way people see, or they call it PRVC, so people see volume control and they feel okay and they feel warm and fuzzy about it. But actually when you flip it on, you would actually have to actively turn it to volume control to change it, which I totally agree with. That's a great thing. So all of these are pressure control ventilatory modes, but they're driven by tidal volume, where they can change the inspiratory pressure up or down in the face of changing compliance or just trying to get to the initial. So say it gives 20 to begin with, it's usually the setting on most things. If you're dialed into 600, you want 600, and it gives 20 for 3 breaths, and it gives 430 normal back, then it will increase that as well. In general, it won't go more than 3 centimeters water pressure change in those breaths in one setting. And if you have something set to say 500, in general, most of them have 100 or 50, say, mils on each side leeway. So it's not always trying to micromanage it too much, but if it's within a general range, it'll keep the inspiratory pressure the same. So say someone's dialed into 500, they get 450 to 550 back average over 3 breaths every time. It's not going to change the inspiratory pressure. So inverse ratio, you don't see this very often unless we're talking about like bilevel or APRV, which we'll talk about in a little bit. But this is anywhere where the IE ratio is greater than 1. Remember that we said obstructive lung disease, you want the IE ratio lower. So this would be where inspiration and expiration are 50% equal or higher on the inspiratory side. Obviously, this is not normal to breathe. So this is, you need a lot of sedation, sometimes paralytics. Like I said, obstructive lung disease, that is no-go for this one. Definitely increases mean airway pressure. And so you got to really keep an eye on your hemodynamics and the amount of pressors you're on, stuff like that. So decreases that dead space ventilation and improve the VQ matching, which is never really proven, but this was kind of this was the start of where we looked at for people with ARDS. And this is kind of where in IRV is what's called. This is kind of where bilevel came from, or APRV, airway pressure release ventilation. So you can see inspiration is up here. This is pressure time. So the pressure's constant over that time, and it kind of gives you an idea of more of the alveolar pressure is being allowed to expand to the same amount that the airway pressure is. Okay, here's the airway pressure, and then this is the alveolar pressure right here. So kind of gives it more time to completely distend all of the lungs. Now you imagine this pressure can't be whopping, or you would create so much barotrauma, which is kind of where the not proven part of this came in. So here's inspiration, here's expiration. You can see inspiration is less than expiration. This was kind of built in. This could be a normal person here. This isn't necessarily them obstructing. It probably is just kind of the way the graphic is, but IRV was made to not let you exhale all the way. That was kind of the whole point of it. So a lot of it started probably before PEEPs came on and microprocessors, but you'd be able to paralyze someone and not let all the airways collapse down, the small airways collapse down before an exhalation happened, into exhalation happened. So HELAX is kind of cool. I did this a few times when I was a respiratory therapist in Columbia and up in Lincoln, Nebraska. And this is called Heliox, if you read about it. So these big helium oxygen tanks, I can't remember H tanks, whatever the big ones are, is an 80-20 or 70-30 mixture. So 20% oxygen or 30% oxygen, and then the other 80 and 70 is helium. So the whole thought process is helium's smaller than nitrogen, which is the normal 80%, 80-ish%. And so if there was big resistance to airflow, whether in the mid airways or upper airways, you could minimize the resistance of going by it. So actually works some. The only time I really saw it used was for status asthmaticus, which down here. And you couldn't use it for CO2 because it could increase your chance of popping a bleb or making pneumothorax with that. So COPD I never saw it used on, but only in severe asthma is where I saw it. The other thought process, which I never saw it used for, was like a fixed upper airway tumor. that was below the cords, but usually above the carina, where you could not ventilate somebody, and it'd be in the lower part, closer to the carina, where you couldn't, you could do one lung ventilation there, you could do a double ET tube, but your chance of, if something's real friable, it's a big nasty tumor down there, you hit that with a double lumen tube, it's going to bleed everywhere, and even if you try and pass a single tube next to it, you might just drown them in their own blood. So this would obviously be something that needs to go to surgery in the very soon. So that's the other thought process. I never saw it used for that, but it was always a good indicated reason for that. So SIMV and VAPS. The VAPS, let's do that first. So this is kind of what we talked about. You'd have a preset minute ventilation on VAPS, and it would go back into a controlled mode that was on before the trial. So that was just one of those ones where you could basically say, here's pressure support, good luck, I'm walking away. And if they fail, it would kick it back on to another one. So yeah, I don't even know if that's a mode anymore, but that's kind of the thought process. SIMV, most people think they know what that is. I always try to quiz people when they want to put someone on SIMV of what it is and draw it out for me, and almost no one can. So you can have PC SIMV, you can have VC SIMV, you can also have PC SIMV pressure support, or VC SIMV pressure support. The first two that I said would just be assume that there was PEEP on there or no PEEP at all, but no one's going to do no PEEP. So basically, when you hit SIMV, you're going to put in a respiratory rate. So a respiratory rate will always be inputted on SIMV. Now you want to keep it low. And the reason we want to keep it low is it's going to create a respiratory cycle. So inspiration, expiration on just the backup. So say we put 6 as the backup as our respiratory rate. We'll look at that over here. So say we put 6 as a title or as a respiratory rate on SIMV, then the controlled cycle time would be 10 seconds, right? 6 divided by 60 is 10. So say the 10 seconds starts right here where this big breath is. Hopefully you can see my cursor again. And the next 10 seconds is right here before the next breath. Say that's 10 seconds. The first breath you would trigger on that respiratory cycle would be a controlled breath of either volume or pressure control. Any subsequent breath after that would be pressure supported if you had pressure support on. The trigger would be the same for both. If you did not trigger any breath after 10 seconds, it would give you an automatic pressure control or volume control breath. And then if you didn't do it in another 10 seconds, it would give you another pressure control or volume control breath, whatever you had. So that's where the minimum rate comes in of, so say we had 6 dialed in and a pressure of 20. If you didn't do anything on SIMV whatsoever, it would be the exact same as pressure control with a respiratory 6 and a pressure of 20, if that makes sense. Anything additional outside of the 6 in any of the 10-second intervals would be pressure support, and that wouldn't be this. Those would be pressure supported breaths, and that would not be the same as pressure control. And so, you could see 3, 4, 5 breaths in between these bigger breaths. So the bigger breaths are the controlled breaths, which are usually triggered by the patient unless they are past the respiratory cycle that's predetermined by the inputted respiratory rate, if that makes sense. So you can see here, here's some pressure controlled, pressure supported breaths in the middle, in between the controlled breaths. A lot of times when you see SIMV, the rate's so low, which it should be, that you see this, you'll see a bunch of breaths in between the controlled breaths. So, down here on volume, which I never really look at, you'd see the big volumes, you'd see a bunch of smaller volumes there, which would all be either CPAP breaths or pressure supported breaths. So I usually do not use pressure or SIMV at all in the OR. You either breathe in or you're not. In general, if we're trying to increase CO2 to trigger you to breathe, you're unparalyzed, and we're getting close to waking up and I want you to breathe, I'm just going to make you apneic, and unless your oxygen goes down, then I'll just decrease the respiratory rate on a controlled ventilation until the CO2 gets to the point where you try to trigger one. Then I'll just turn it off and put on, or go straight to pressure support. So in the ICU, I didn't see much advantage for this, except for like really chronically ventilated people, or really hard people to get off the vent, or they couldn't tolerate a weaning trial, and you might want to put them on SIMV for hours to help decrease the atrophy of their diaphragm. The other scenario would be like long-term vented people in vent hospitals or something like that. If they couldn't tolerate a completely assisted type of ventilation, then an intermittent controlled breath every now and then might help minimize the atelectasis, help pop some of their alveolus open, and give their diaphragm a little extra break if it couldn't tolerate having completely assisted breaths. So it's kind of what SIMV looks like. I don't ever use it in OR, but every time a student or a resident or something tried to use it, or an intern underneath me, I always try to question them about what they're actually doing. And I can't remember a time where they actually knew what the mechanics of it. You kind of know the ideal, but do you know what would happen during every breath initiated during what time cycle? So here's what we talked about. This is a form of IRV, or inverse ratio. This one used to be it was pretty hot there for a while. Bi-level APRV, same thing. And we had some decent studies on it. Maybe it helped, maybe it didn't. Maybe it helped for a little bit. But basically it's an IRV mode where it's a dual CPAP, which is kind of the bi-level. That's where that came from. It's a bi-level of CPAP, a really high CPAP, and then a lower CPAP in between. And then people with obstructive lung disease didn't do very well with this, especially with the lower expiratory time. And if they had an elevated CO2 at baseline, prior to anything, they walk around with a compensated respiratory acidosis. This really wasn't good for them. But young, especially young, healthy people that had serous sepsis, ARDS for whatever reason, severe, they're on 100% FiO2, your peak pressures are getting north of 30. This would be a good one to try, at least. On APRV, you can see the high inspirations right here on the top of the blue. You can see that's the high CPAP phase, and then there's a lower CPAP phase, which you can see the release phase. Not a lot of time for exhalation, but it definitely kept everything kind of open and whatnot. You definitely wouldn't want this pressure up here. See, up here is 30. So bi-level, you're not putting it to 40 and down to 10. It's more like, 20 and 5, or, 20, 25 and 5, 25 and 10, something like that. So this was very stimulating for the patients. So they definitely need to be sedated well. A lot of them are on pressors, so you couldn't sedate them that much. Otherwise, your pressor is going to go up. So I have to watch your mean airway pressure, which mean airway pressure is calculated on every vent I've ever seen in the OR or the ICU. You get much north of 15 on that, and you're going to be worried about venous return and interthoracic pressure going up. So, and you can see here, we would paralyze some of them, but if you could just barely sedate someone and they tolerate it, especially the young, healthy people that had a good respiratory drive and good lungs, you would see that they would actually breathe CPAP breaths at the high inspiratory CPAP level here. So that's what these are. These are little CPAP breaths. You can't tell too much there, but you can see the pressure. The pressure is trying to stay constant, so it's changing the flow rate to give that to them. And of course, this is technically it's an IRV, but it's a form of a pressure control. So PCIRV is probably the appropriate stated name for that. And then these would be CPAP breaths on here, which is kind of cool to see, but I don't know if they use it that much anymore. I know it's kind of difficult. We have pronine and all that stuff, and ECMO is more common now. And so we'll kind of wrap some stuff up here. So this is where I'd really lose people. Actually, I'd lose them quite a few slides ago, but then when I started talking about oscillators or jet ventilators, it really kind of threw people into sideways there. So I think that definitely knowing that as a med student gave me such an advantage over all the other stuff. So oscillator settings, you can kind of read this. Most of the oscillator stuff, I never saw it used on adult. I'm sure it was somewhere, but not where I was at. Mainly this would be little neonates. And if you see, let's see what, yeah, here's the oscillator that, I don't know, I'm sure there's a new one now, but you'd see this is the big diaphragm that would kind of oscillate back and forth. And then you'd hear the thumping in the NICU. That's what it was. So most of the time it's real bad preemies or deformities, cardiac defects, release surfactant deficient, people that needed FiO2s at 100%, which is really bad for neonates in their eyes with the free radicals. So this would help minimize the FiO2 requirement. So you can kind of see on here the frequency. You didn't do it in respiratory rates anymore. It was at hertz. So you can calculate what a hertz is, but 5 hertz was a respiratory rate of 300 per minute. So if you ever went into NICU and heard something thumping like that, that would be the oscillator. So here's the settings you could affect: the eye time, the hertz was the setting, and then the amplitude. So those are just little dials. There's probably something more specific now. I assume they still use these, but so here's kind of the oscillator thought process. The respiratory rate is going so fast. Here's the oxygen. The CO2 would actually curl around it. And remember, all these kids, there's uncuffed airways. So CO2 would come around the ET tube. Now this has a cuff, but most of them are uncuffed. Or they have a cuff, but we just don't inflate them most of the time. But for oscillators, if the pressure got so high, you might have to put just a little bit in there. And of course, that'd be guided by a manometer, which is kind of funny in respiratory therapy. I always was hooking a manometer up to see what the pressure on the balloon was, and now we never really do that in anesthesia. But of course, people are intubated for way less times in anesthesia. So, but it makes you think in these big, big long cardiac, thoracic, brain case, whatever, you probably should test the pressure in the cuff, just so you don't get ischemia of the airways. So here's kind of what a waveform would look like. This is your pressure, of course, your volume down here. So, okay, well, that's about it. So if you got any questions, you're welcome to, put them in comments or email me or something like that. But I hope this helps. And if you need anything, you are welcome to get a hold of me. Thank you.